Hello, my friends. Trying to record a video here telling you how to utilize the Cat EI tool. So let me share my screen with you and we will rock and roll here. So this is the Cat EI tool for this specific article, right? This is by Mohammed Taher Ahmed. And we're looking at the effect of transcutaneous electrical nerve stimulation, TENS, on postoperative pain and inguinal hernia repair. So we're starting with the title. We literally put that there. Who's the authors? Where's the journal? Volume, year, who reviewed it? When did you review this? Okay. Now we start moving into the actual CAT EI tool. And the first thing we do is we fill out the PICO for it, right? Population, intervention, comparison, outcome, time frame. If we look here on the tool, we can see that I highlighted these things on the tool for you so you can see, right? The PICO, who is it? It's 67 males with the physical status here who underwent an elective inguinal hernia repair. Those are the people that we're doing this study on, right? So that's the population. Intervention is TENS, right? So what did we do with them? We're using TENS, either an active TENS or a placebo group. So that's our intervention is TENS. What is the dosage that was done there? Well, the dosage is here in the intervention. It tells us all about what we did for the patient. Here it is right there, right? The intervention, A1, the intervention. We roll through frequency 0 to 160, intensity 0 to 100. They received it at 100 hertz at 120 microseconds, 10 to 30 milliamps. That was their actual data, like what the parameters they used, right? How frequent? 30 minutes, 2 times a day for 5 consecutive days, right? That's what it told us here. That's what they were doing with this treatment here. The outcome, what were the outcomes that they used for this? There were three of them. They used pain, this visual analog scale of pain. They used the change in the serum cortisol level. That's what SCL means. And they used how often they asked for medication, like analgesic medication. Those are the three outcomes that they measured. And again, they're talking about all of these here in the results, but they also go through that in the materials, the methods themselves, as well as they tell you right in a lot of the information we're doing in this PICO is right here in the abstract for the article itself. Time frame, I already mentioned that. Okay, what's A2? Study setting. Where did this article, like, where did this happen? Well, A2, we can see it was right here, the General Surgery Department at the teaching hospital in Cairo, Egypt, right? So that tells you right away it is an acute care setting, not laboratory, inpatient, or out clinic. And it was an urban setting in Cairo, Egypt, right? So I always just put here that a study conducted teaching hospital in Egypt. Did it comply with IRB regulations? This is A3 we're looking at here. Normally, before you actually started talking about, like when you talk about the subjects and all that kind of stuff here, it would tell you usually right about here after the exclusion inclusion criteria that this study was approved by an IRB board and it went through that process. This article does not include any of that. So therefore, I check that as being no. Okay, now we get into the B's, right? And if you looked at the top of this document, right? So here's where it was on the other side, going through this. At the very top of the document, they have this whole list of the B's. Like, what does it mean to select yes or no? And this is what you need to use to choose whether you're selecting yes or no. So for B1, we're talking about inclusion criteria. Yes, if the inclusion criteria is described in sufficient detail. No, if it lacks clarity. Well, this article is very clear on what here's their inclusion criteria. Here's their exclusion criteria, very clear. So therefore, for B1 and B2, I selected yes. Do the recruitment methods reasonably attempt to minimize bias in the sample? So this is one of those kind of subjective-y type things, but it seems to me here they were trying to make sure that they had very specific patients that were outlined by their physical status and all of that. They didn't really recruit from different hospitals. It is kind of a one location, but it was randomized, double-blind, placebo-controlled. So therefore, I went ahead and checked yes for that one because again, our B3 basically saying we're trying to minimize bias. That's what we're trying to do. So again, I selected yes. If you would have selected no, I would not have been upset about that. I think there's a little bit of a variability there with B3. B4 was an a priori power analysis used to determine the minimum sample size. If you look at the article right here, they run through. Here's what we need to do in order to we need to get a 60 sample, like 60 subjects is what we needed to get a good power rating. In other words, will we have enough people to run good statistics on? That's what really this a priori uh, power analysis. That's what it's trying to tell us. And yes, they definitely did that. Were the participants randomly assigned to intervention groups? That's B5. If we look here on B5, we can see that yes, they were randomized, right, according to the schedule that they prepared before they started the study. So there, yes, for B5. B6 was the allocation to the treatment group concealed. In other words, did the subjects know uh, uh, that they were in a TENS group or a placebo group? Were the subjects blinded? And definitely they were blinded, right? We know that they did not know who was who. And we also know that the therapists themselves did not know. One therapist knew whether it was took the measures and things, and the other one actually knew whether they were in the placebo or the active group. So therefore, yes, for B6, that was good. Was it controllable? Yes, we did a placebo. Were the subjects blinded? So again, this was the treatment allocated, and I apologize, I said that the wrong way. This is did the researchers know it was blinded? So that's definitely yes. And did the patients know they were blinded? Yes, they didn't know. They just got the TENS unit put on them. If you read, let's see, this is B8. If you read here, it said that the patients were informed that two types of TENS treatment were being tested, one in which they were strong but comfortable tingling sensation would be felt, and the other in which little or no sensation would be generated. The placebo TENS group received no electrical stimulation, but the unit displayed an active indicator light suggesting to the patient that the unit was active, right? They wanted them to think they were getting TENS, even though they weren't actually getting them. So that's a good definition of what a placebo means. Are the interventions for all study group described in detail? Yes, they did a real nice job of telling us what they were going to do. This is all this right here. This is B9, telling us everything that they did. And then here's the placebo group, what they did there. So very, very clear what they did. B10 was adherence to the study protocol described. In other words, did they go through to make sure that they actually followed? This is what B10, let's see what it says here. Yes, if the study describes acceptable level of attrition, planned crossover, subject compliance, any of the conditions. I said yes for this one. They didn't really go into a whole lot of detail about these different levels of attrition and things. If we go to the results here, they talked about a little bit of that. They had 7 patients were excluded due to the post-operative complaints, wound infections, and other wound difficulties. So really, this is why I chose for B10 to be yes. And I apologize, I didn't put that there. I'll make sure to do that before I save it for you all. B11 was the presence or absence of adverse effects described. I checked the no because, again, in this results section, if there were adverse effects, they would have told you that. Adverse effects is meaning something that we don't want to happen, some bad thing that happened. Now, I guess you could potentially call this in these wound infections and other wound difficulties as being adverse effects. So you could have theoretically said something there, but I put no for that one. And then, were there conflicts of interest that were talked about here? Usually at the end of the article, they would talk about their conflict of interest. Normally, there would be right after this whole conclusion here before the acknowledgments, there would be something here about conflicts of interest. And they did not include any of that. So I checked no there. And then I tallied them all up. I got 10. So next, we come to the outcomes. So 3 outcomes: pain, serum cortisol level, and request for analgesic drugs. How they measure that? Visual analog scale, the venous blood sample, and then the number of doses of medication they got. Those are the measures that were used. And then we're evaluating each of those outcomes with these different questions. For each outcome of interest, was a measure chosen that has established validity? So you don't have to know this. The author should tell you that they are valid instruments and give backing for that. And if you look through, again, these 3 different outcomes, the results sections, they talk about them in particular, they don't give any backing for why they chose what they chose. So that's why you can see all these are checked no as far as validity goes. Do they have an established reliability? and again, they didn't give us any information about reliability in their article. Was the reliability level of the testers reported? They didn't talk about that at all. Was the testers' data collection blinded? Well, we know yes, the people who were collecting data were blinded, so we checked yes for those guys all across the board. Subject analyzed in the groups which is they were assigned. So if you're going to look at D17, again, all the information about what to select is all here. So they talk you through these things. If intention to treat was reported, intention to treat analysis means the subjects were analyzed within the groups they were originally assigned to, regardless of their adherence, whether they kept up with the protocol. The intention to treat analysis provides a conservative estimate of the effects because it includes contamination from unplanned crossover and dropout. In case of missing data, the researchers should specify the message used for inputting of missing data. Regardless, the original number of enrolled subjects must be included in the final data set. And they really did not talk about this in any significant way here. So therefore, those were all checked no. Did the sample size meet the power recommendations? Again, if you remember that a priori, which means before you start power analysis, that we said we should have 60 subjects is what we needed. And they increased to 67 for possible dropouts. Well, how many subjects did they actually end up happening? Well, they had 67 people. So that's good. They had the same number that they wanted. So therefore, we clicked yes across for all three of those. For each outcome of interest, are the study groups equivalent at baseline? They are. If you looked again at their analysis of this guy here, B19, no statistically significant differences between these different groups. That's what this says there. So we could definitely check that as being yes, all the way across the board. For B20, for each outcome of interest is the estimated effect size and its precision reported. So yes, they gave us some lovely charts here that talk about what happened with the TENS group. This is for VAS. With the change in cortisol level, they give us some numbers that go along with there. Even though there's no significant difference. So therefore, they didn't really conclude too much there of that on table 4 here is where they did that. And then, and you can see they have pluses and minuses, right? So they're giving us some data. If you look at the instructions for this particular section, do they have number of groups, sample size, observed mean, standard deviations? These are things about effect sizes that we want. They could certainly have done more. There are more statistics you'll learn about that would have shown more precision about how big of an effect this has. But this did include these these pluses and minuses, standard deviations, basically, for each of the three, except they didn't include that for outcome 3, the request for analgesic drugs. All they did was just basically give us this one table here that talked about TENS versus placebo. They didn't give us any more information really about that. So therefore, that was marked as a no. And that's the thing to make sure you understand. You don't have to have the same things 1, 2, and 3. Different outcomes may have different check marks here depending on what they do. We tally those all up, 4, 4, 3, and now we come to the quality rating. If we look here, I think this is fairly subjective. High quality, acceptable; low quality, unacceptable. They give us this kind of statement. High quality, randomized clinical trials, greater than 80% follow-up. So they didn't lose a whole bunch of people. We have blinding, we have randomization. That's really what goes for there. So I said, yes, it was a high quality study for these two outcomes because they didn't report anything other than just the number of here like this. They didn't give us any effect sizes or any sort of other statistics for outcome 3, the request for analgesic drugs. I just made that a 3, so I thought acceptable quality, but still very good for there. Last but not least, you get to the C's. Is the conclusion justified? Like, well, their conclusions, and if you were to read what their conclusions are, they say, well, let's look at this here. It's easy. Our results indicate that TENS is beneficial for post-operative pain relief following inguinal hernia repair. No side effects are observed. Its pain-reducing effort lasted more than a month post-operatively. Consequently, the routine use of TENS after inguinal hernia repair is recommended for its short and long-term effectiveness. Does that make sense based upon what they found? Yes, it does. Were the limitations in the study reported? Yes, they were. There's a whole section here that talks about in the discussion about their limitations there. I didn't mark that there. So here we go. Limitations here talks about what they could have possibly done differently. So yes, that's recorded. Could the interventions be used in usual practice? In other words, was this some crazy something that only people who are very talented and have lots of money can do? No, you got a TENS machine, you can do this. So there are no cost considerations that might impact clinical unity. And was the follow up long enough? So they give 30 days. I think that's plenty of time worth there. So I made a comment saying no validity or reliability measures for the outcomes were given by the authors, just to make that statement there. So hopefully this is helpful for you. Again, I want to post this highlighted copy up on Learning Hub so maybe you can see a little bit easier of how I chose to do what I did. Hope that's helpful for you. Let me get out of here, stop sharing my screen, and we'll call it a day. See you.